Hi, everyone. Welcome to today's Student-Led Journal Club and Case Studies Seminar. My name is Anne-Marie Hayes. I'm a research associate for the Joplin campus of KCU. Today, I'm going to be introducing our speaker, student Dr. Luigi Loizzo. Student Dr. Loizzo is a second-year medical student at Kansas City University from Chicago, Illinois, where he received both his undergraduate and graduate degrees from Loyola University Chicago. He worked for several years as a clinical research manager, overseeing inflammatory bowel disease studies before matriculating into medical school. Throughout this time, student Dr. Loizzo also developed an interest in community health, including published research investigating the relationship between housing segregation and health outcomes, in addition to completing a preventative and public health internship during the summer of 2022. It was through these experiences that he became passionate about the intersection between the management of chronic disease, psychiatric care, socioeconomic status, and how they influence patient care and health outcomes, which this presentation will explore in further detail. His current specialty interests include psychiatry and gastroenterology. So with that, the floor is yours, student Dr. Loizzo.
Thank you so much for that introduction. Like Anne-Marie mentioned, my name is Luigi Loizzo. I'm a second-year medical student at the Kansas City campus of Kansas City University. And today I'm going to present on a sort of literature review, but a general conversation on the psychosocial toll of inflammatory bowel disease and how it influences patient care outcomes. So first thing is, first thing is I wanted to discuss a little bit of why I'm interested in this kind of research. So for about 5 years after undergrad, before matriculating into medical school, I had the opportunity to work as an inflammatory bowel disease clinical research manager back home in Chicago at Northwestern. And it was through this experience that I really was able to see inflammatory bowel disease patients in their most vulnerable states. I was able to see them throughout all different parts of the disease progression. On the left here was my research mentor, Dr. Stephen Hanauer, and he really highlighted in his clinical practice the importance of addressing the entire person. Chronic diseases can be extremely unrelenting in terms of patients' mental health. And I saw anecdotally that patients' mental health was intrinsically tied with their disease outcomes in inflammatory bowel disease. So when thinking about this, I was intrigued to sort of see if the literature reflected these anecdotes and if they were generalizable, and to see if there was any research done that studied the investigation of negative mental health outcomes and negative inflammatory bowel disease outcomes. So that's sort of what we'll talk about for today's presentation. So as sort of some introductory material, I wanted to quickly go through some aspects of what inflammatory bowel disease actually is. So as a lot of us know, inflammatory bowel disease is categorized into two broad pathologies, one being ulcerative colitis and the other being Crohn's disease. So although they, can present similarly, they do have different aspects of the disease in terms of where lesions are presented in the colon, different layers that the pathologies affect, and also how this affects disease outcomes. So just for some, on a molecular basis, ulcerative colitis is typically characterized by inflammation of the mucosal layer, whereas Crohn's disease is more of a transmural inflammation. And something I also wanted to point out is now with the increase in diagnostic tools and screening tools, we're seeing a lot of individuals being diagnosed with inflammatory bowel disease in their adolescent and young adult years, as opposed to older adulthood, like inflammatory bowel disease sometimes tended to be diagnosed with in the past. This was a graphic that I really liked that highlighted the differences between Crohn's disease and ulcerative colitis. So Crohn's disease can happen anywhere in the GI tract, whereas ulcerative colitis is limited to the large intestine and the colon. The patterns of inflammation are also a little bit different, in addition to the appearance of inflammation as well. The location of pain tends to be different in the two pathologies, but in my own personal experience, the clinical symptoms can sort of mesh together. So the importance of making the diagnosis of inflammatory bowel disease depends not only on imaging and colonoscopy, but also immunohistochemical analysis as well. And I also wanted to talk about the pathogenesis of inflammatory bowel disease. So in Crohn's disease, we see more of a Th1 response as opposed to ulcerative colitis, where we see more of a Th2 response. In Crohn's disease as well, it's been studied that NOD2, which is important in a lot of immunological cell function, is mutated, which leads to an activation of NF-kappa B, the NF-kappa B pathway, which leads to downstream activation of autoimmune inflammatory lesions in the colon and throughout the digestive tract. And the last thing is sort of our introductory material talking about inflammatory bowel disease is the management of IBD. And this is something that I really was interested in when I worked as my time as a clinical research manager. So when I started, there were only a few medications that were sort of considered first line for patients for inflammatory bowel disease. And by the time I stopped working before medical school, we had like about 8 to 10 additional medications for these patients. So we sort of treat it as a stepwise approach. So if patients present with mild disease, we'll typically prescribe things like 5-ASA, some antibiotics. Once we get to the more severe stages, we opt for the oral corticosteroids and immunomodulators like azathioprine. If patients do present or progress to severe disease, that's when we're going to get our biologics like adalimumab, infliximab, and this is really where the landscape of inflammatory bowel disease treatment is exploding. So outside of a lot of these medications, we're also coming up with new immunomodulations that are really helping these patients. Something I also wanted to mention is that the use of corticosteroids is starting to be weaned down a bit, but it's something that's still prescribed heavily, both anecdotally and throughout the literature as well for patients who are experiencing inflammatory bowel disease at any stage if they present with what we call a flare. So that's just going to be a severe exacerbation of their disease. Unfortunately, right now, oral corticosteroids are probably among the best therapies in sort of attenuating that response in order to get the patients less sick so that we can modulate their treatment plans. So now that we sort of know a little bit more about inflammatory bowel disease, I wanted to discuss the toll of living with and managing an IBD diagnosis. And a reason why this was very important to me is because I really saw the way that a chronic disease like inflammatory bowel disease really affected our patients in the clinic and affected every aspect of their life. So like I mentioned in the beginning, I was really interested to see if the literature reflected this and if there was research done creating a tie between mental health effects and the outcomes of inflammatory bowel disease patients. So just talking about the burden of inflammatory bowel disease, it's not cheap to live with IBD, so both Crohn's and ulcerative colitis. So a study in 2008 actually showed that there were, an average cost was $18,000 per patient per year in the US, which is not very cheap. And I also wanted to highlight that inflammatory bowel disease is a pretty significant burden on the healthcare industry in this country. So it can cost up to $31.6 billion per year in terms of the burden that is placed on the healthcare industry. So it's a pretty significant disease, much like other chronic autoimmune inflammatory diseases. So I thought this was very interesting. So a recent study applied the cost outcome measure. And what the cost outcome measure is it was a pretty simple survey of about 12 questions or so developed at the University of Chicago. And it's typically applied to cancer patients, but a group of researchers wanted to see if this could be applied to Crohn's disease patients. So they found that through this research study, a majority of patients with Crohn's disease experience at least mild financial distress. It also found that lower income and education levels increased disease activity, and the presence of anxiety and depression increased the financial distress experienced by these patients. And this was something that sort of hit home to me. One of my first patients as a clinical research coordinator before I progressed throughout my few years at Northwestern, a patient who was typically always happy, always excited, had failed the top level of therapy that was available at the time. And so we were responsible for offering the patients different therapies that were down the pipeline in terms of clinical research. And the patient, looked at me and just said, I don't know how long I could keep doing this anymore in terms of having these exacerbations. So that has always stuck with me. And I think it's important as future providers and current providers that we really take into consideration the mental health symptoms that can develop in patients with chronic diseases like inflammatory bowel disease. So after reading this research study and sort of touching on the cost that it takes to have inflammatory bowel disease in this country, I wanted to really assess if there was a link in the literature between inflammatory bowel disease, anxiety, and depression. So I found this research study, which I thought was pretty interesting. And this was evaluating about 70 patients with a mean average age of 36 years. And they found that the prevalence of depression and anxiety and the severity of depression was higher in patients with inflammatory bowel disease as compared to control patients. This study also had a few important considerations that I wanted to highlight. So a lot of the times we group inflammatory bowel disease together, even though they're two separate pathologies of Crohn's disease and ulcerative colitis. But something I noticed looking throughout the literature exploring this topic was that the data was pretty similar when it came to Crohn's disease and ulcerative colitis, highlighted here by the study finding that the prevalence of depression was not necessarily different between ulcerative colitis and Crohn's disease. Something I did find interesting as well was that patients with severe Crohn's disease had more severe depression. This could be for a few different reasons. Typically, Crohn's disease patients, because it can affect a larger portion of the GI tract, do develop more severe exacerbations. So that could be one possibility to explain this discrepancy. I also thought it was important to highlight that the mean duration of disease and the history of corticosteroid treatment or surgery for IBD were not associated with the presence of depression or anxiety, showing that a diagnosis, no matter at what stage of the disease progression that these patients are in, can negatively affect mental health outcomes. Another study I found, which was pretty interesting, was that a study evaluating 262 patients discovered that illness perceptions and depression were associated with reduced HRQOL, so that stands for healthcare-related quality of life, in patients with IBD, even when controlling for demographic and disease factors. So what this study was really highlighting was that when taking all things into account, a diagnosis with inflammatory bowel disease can lead to decreased healthcare-related quality of life. Negative mental health outcomes are prevalent in IBD patients with varying stages of disease activity, which is another thing that this study highlighted. So in their 262 patients, 75% of those patients actually were in remission. So they were not currently experiencing any disease exacerbations from their Crohn's or ulcerative colitis. However, they still did report statistically significant data that showed decreased healthcare-related quality of life. So a reason why I wanted to include this is because it's important to really be asking these questions as a provider and checking up on our patients' mental health, even if their active disease or inactive disease isn't necessarily providing exacerbation of symptoms. So now that we've talked about the linkage between inflammatory bowel disease and that there's a demonstrable link to decreased quality of life caused by prevalence of anxiety and depression, I wanted to see if there were anything in the literature that really discussed specific points on how depression, what exact examples were present. So one study I found, which I really liked, published last year, took a look at a cohort of 71 IBD patients. And about a third of those patients reported that they had poor sleeping habits. So to investigate this further, the researchers grouped the patients into groups that slept poorly and then compared their emotional states. So what they found was that patients with poor sleep had a higher PHQ-9 score. So with a PHQ-9 score, it's about a 12-question survey that measures patients' mental health. So there was a correlation, which we could see on the graph on the right here, that patients with bad sleep that had inflammatory bowel disease also had higher scores on that PHQ-9 survey. So this is, again, showing a link between anxiety, depression, lower quality of life, and how it can affect patients' sleep and therefore overall quality of life as well. Another negative effect of IBD I found interesting was the effect on cognition. So something I liked about this research study, which I thought was very important, is that it had both subjective and objective measures. So 61 patients with Crohn's disease specifically were analyzed in this research study, and about half of these patients mentioned that their subjective cognitive abilities were deteriorating and that they were experiencing cognitive fatigue. Again, the part that I liked about this is that this subjective component was corroborated by objective measures. And as we can see on the right, these are some negative cognitive symptoms that these patients objectively displayed. IPS stands for information processing speed. So this was the one that was affected the most in these patients, followed by verbal cognition, attention, visual, spatial, and memory. So a lot of these patients too, when they were interviewing them, said that not only did this affect their working ability and their ability to have interactions with people at their job, but it was also affecting their interpersonal relationships and their romantic relationships as well. So this is really highlighting how we really need to be looking at these in our patients with chronic diseases like inflammatory bowel disease. So outside of sleep and cognition, something I wanted to look at in the literature was inflammatory bowel disease effect on employment. This was something that was brought up many, many times during my time as a research manager. Patients would constantly be taking sick leaves with disease exacerbations, especially if they were not in remission yet or were starting the loading doses of their medication or other therapies. And this is something that our doctors were constantly working with our patients' employment about, is, trying to work through a system where the patients felt like they could stay in their employment while experiencing their active disease states. So a study in 2016 investigated 202 inflammatory bowel disease patients, and the average age of these patients were 41 years old. So this study found that 19% of these patients had active disease at the time of the survey. 61% of these patients had normal paid employment. And I thought these numbers were really interesting. 25% of patients were currently on sick leave because of their inflammatory bowel disease symptoms. And 23% have received a disability pension because of their inflammatory bowel disease symptoms. So this just shows that inflammatory bowel disease can significantly impair people's ability to work. Another thing I wanted to highlight from this research study is that a large majority of patients at work experience difficulties such as concentration problems, having to work slower than normal, having to seclude themselves from their colleagues, especially having to go to an area that was close to a bathroom in case they needed it. And they also found that there was a delay in the production of the work. So this research study showed that not only were patients, prompted to take sick leaves or disability pensions because of their disease exacerbations, but the patients who were able to work in paid employment had negative effects due to their inflammatory bowel disease symptoms at work, also highlighting that negative effect on their quality of life. So on top of their employment, another thing that was really heavily discussed with patients in our clinic was sexual dysfunction and how inflammatory bowel disease had its effects on that. So this spanned the gambit of people who were in long-term relationships, concerned about how their inflammatory bowel disease symptoms would affect their relationships there, and also with our younger patients, going into the dating scene and expressing a lot of anxiety and a lot of worry with their inflammatory bowel disease symptoms. So I found a really interesting meta-analysis that included 11 studies with over 8,000 patients as a sample size. And the meta-analysis found that IBD was significantly associated with worse sexual function in both sexes. More specifically, IBD patients had worse performance on specific subdomains of sexual function compared with individuals without inflammatory bowel disease. So for men, it specifically increased erectile function and satisfaction. And for females, this was mostly affecting subdomains of sexual function. So this is something that can be an awkward conversation with a lot of patients, but it's really important to, once establishing a comfortability with your patients, to ensure that this aspect of their lives is also not being negatively affected by their inflammatory bowel disease. So next we have, and most importantly for the discussion today, is inflammatory bowel disease effect on self-image. This was something that was really prevalent in our patient population because inflammatory bowel disease is associated not only with a lot of procedures that can alter the way that people look and their self-image, but also a lot of medications that can exacerbate certain symptoms that can cause the patient to have a negative self-image as well. So this research study analyzed 330 adults with inflammatory bowel disease, so both ulcerative colitis and Crohn's. They found that body image dissatisfaction was associated with increased disease activity in steroid treatment, but not with immunotherapy or biological therapy. And the reason why I wanted to highlight this specifically is, as a lot of us know, steroid treatment, especially oral corticosteroids, can have really negative system-wide effects like moon faces, aches, pains, growth of body hair in different areas. So this was really intrinsically tied with the way that people viewed their body image. Specifically, specifically when it came to steroid treatment. Unfortunately, like I mentioned in the beginning, steroid treatment is currently one of the only things that we can sort of have act as a band-aid for patients who are experiencing a severe disease flare. And corticosteroids can be used for a few months before we actually see an attenuation of the patient's symptoms before altering their treatment. So this is something that can affect, a large majority of the patients here if they're going through a flare. So it's something to really consider and highlight here. Additionally, body image dissatisfaction was associated with low levels of general and IBD-specific quality of life, sexual satisfaction, which was highlighted in the previous point, and high levels of anxiety and depression. So this is just really important to consider that when giving a patient a diagnosis with a chronic lifelong disease, it's really important to upkeep the patient's mental health and make sure that the patient isn't deteriorating in terms of their mental health, because as we've seen from the literature so far, this is directly and intrinsically related to the patient's quality of life, both with their disease and outside of their disease. So this is just sort of highlighting of like, why do these things matter? Are they interrelated? So we do see that these things can compound on each other and just really cause a spiral for both the patient's healthcare outcomes and both their self-image. So if we have negative sleeping effect because of our inflammatory bowel disease symptoms, we might have impaired cognition. If we have impaired cognition, we might have work-related performance issues. So I wanted to highlight here that these things don't exist in a vacuum. They're very interrelated and they can compound on each other. So as providers who are managing inflammatory bowel disease patients, it's really, really important to take all of these things into consideration on top of the patient's medical treatment. So also I wanted to highlight that this does not only happen in adult populations. Pediatric populations now more than ever are being diagnosed with inflammatory bowel disease like we previously discussed. So I wanted to exemplify that by finding a study in 2020 that investigated 130 adolescents and young adults aged 14 to 25 and examined whether embarrassment of the condition and social self-efficacy mediated the relationship between certain symptoms of inflammatory bowel disease. So they found that 10% of the patients reported mental health symptoms, including severe anxiety, moderate or severe depression. And another thing which I thought was interesting that wasn't necessarily measured in the adult populations were loneliness. So this study found that not only was disease severity and pain predictive of poor mental health, but embarrassment about patients' conditions was shown to increase depression, anxiety, loneliness, mediating the relationship between disease severity and well-being. And as we know from our previous studies, we know that this is intrinsically and directly related to the patient's overall quality of life. This I also wanted to highlight. So when researching this, I was very interested to discover if patients had better health outcomes in terms of their self-image and mental health if they were diagnosed at a younger age, so more around 10, 11, 12, or diagnosed at an older age, where anywhere from 20 to 25. And this study actually found, and some other studies that I looked at, found that there's a sensitive period. So the older you're diagnosed in terms of being an adolescent or a young adult, that later diagnosis was correlated with worse mental health and therefore healthcare quality of life related outcomes. So this sort of led researchers to believe that there's a sensitive period where if you're diagnosing a patient with IBD from anywhere from 17 to 25 years, it's very important to also have mental health interventions as well in order to prevent this from occurring. So this is just, again, another research study that analyzed the pediatric and adolescent population that I wanted to highlight. So embarrassment is not the only issue. So a study in 2011 investigated 262 IBD patients, and these patients were aged 10 to 20. So the one thing I thought was very interesting about this research study was that negative illness perceptions and depression were more strongly associated with lower healthcare-related quality of life than demographic and other disease factors. So the reason why I think this is important is because depression and negative illness perceptions are tangible things that we can use in terms of intervention to help attenuate these things. And this is a lot easier to change than demographics and certain disease factors. So this just shows that there's really a lot of space for interventions to help these patients. And so for a lot of the research studies and a lot of the literature that talked about pediatric and adolescent patients, it's sort of a multifactorial approach on how to treat these patients in terms of their quality of life and also their inflammatory bowel disease symptoms. So one of the most important things was really tackling these interventions during the critical period, which is that later stage of adolescence and early adulthood in terms of new diagnosis of inflammatory bowel disease, and also addressing the embarrassment to mediate the relationship between disease severity and well-being. And like this research study highlighted, it's really important to include interventions targeted towards reducing negative illness perception and depression in these pediatric patients. So one thing that was anecdotally seen in our clinic is our patients who are struggling with their mental health had a really difficult time adhering to treatment. And that was both long and short-term treatment and also diagnostics. So imaging, blood work, the colonoscopies that they had to have. I wanted to see if this was generalizable, and I found research studies that showed that psychological symptoms in adults contributed to poor treatment compliance, which of course further worsened their outcomes for inflammatory bowel disease and their quality of life. So this specifically looked at depression and anxiety in the setting of IBD, which was shown to decrease short and long-term efficacy of infliximab treatment. And the reason why I wanted to highlight this specifically is infliximab treatment was the first monoclonal antibody treatment used for inflammatory bowel disease, approved way back in the 90s. So this is one of the standard of care treatments if patients have moderate to severe disease. So this is just showing that depression is really, really impactful on disease treatment of medications that are commonly prescribed to our patients. I also wanted to see if this was more of a phenomenon that was restricted to our adult IBD patient populations, but I was able to find certain studies that showed that this was true in pediatric and adolescent populations as well, which is what the second point is highlighting. So this study looked at 79 adolescent patients and revealed that anxiety and depressive symptoms moderated the relationship between barriers to adherence. So now that we've sort of talked about that, it's sort of a lot of gloom and doom. So our inflammatory bowel disease patients tend to have more prevalence and severity of depression and anxiety. And we looked at 5 different tangible points on how this affects patients' livelihoods in terms of sleep, cognition, sexual health, well-being, body image, and also how it affects their treatment outcomes. But what I wanted to really highlight in this presentation is that there are interventions that providers can do to help address mental health concerns to improve disease outcomes in IBD patients, demonstrated by both clinics across the country and the literature as well. So one thing that I really want to highlight is the opportunity for intervention here. So on the left-hand side, I was able to find a 2017 study that used a survey that had a huge patient population. So we're talking over 2 million individuals with inflammatory bowel disease. And it found that only 36% of the patients with depression or other mental health symptoms actually visited a mental health professional or a psychiatrist within the past year. So this is only about a third of the patients experiencing these anxiety and depressive symptoms who have inflammatory bowel disease seeking out that help. Despite this, which is this point on the right-hand side here, research has been done that investigates psychiatric-specific therapeutic interventions in IBD patients and found that psychotherapy was effective for improving quality of life, perception of stress, anxiety, and depression, as well as inflammatory bowel disease symptoms. So not only is there, what I wanted to highlight here is that there is a clear underservice when it comes to patients seeking out these mental health professional services, but we also know that seeking out these mental health services lead to both better mental health outcomes and also inflammatory bowel disease outcomes. And so this is the perfect place for intervention. And this was highlighted at my time at Northwestern. So we actually had our inflammatory bowel disease clinic in conjunction with our GI-specific mental health clinic. So a lot of the times our patients were able to see their inflammatory bowel disease physician and immediately go see their psychiatrist or psychologist. And these providers were specifically trained for inflammatory bowel disease patients. Again, this is anecdotal, but in our personal experiences, we saw that patients who were regularly catching up with their GI-specific mental health providers had better IBD outcomes in terms of having their medications last longer, having less flares, and overall having a better disease outcome. So this also, going on top of this systematic review published in the Journal of Psychosomatic Research evaluated 43 studies that investigated the relationship between psychiatric treatment and IBD outcomes. So because it really took a wide look at the outcomes, I wanted to highlight the findings here. So 5 studies showed that antidepressant use was effective in improving disease activity and gut and GI symptoms. So this again is highlighting the important aspect that treating the mental health of patients with inflammatory bowel disease has a demonstrable effect on improving the inflammatory bowel disease symptoms. The studies reviewed also showed that despite higher use of psychopharmacological treatment, only a low proportion of patients had access to psychiatric consultation and psychotherapy. Again, highlighting the previous point that having these accessible for these patients is really necessary in helping them not spiral down in terms of their course of their disease. 2 other points I thought were pretty interesting from the systematic review. They found that 1/3 of studies reviewed found that psychotherapy was effective for people with IBD for at least one of the outcomes evaluated. So this could be quality of life, coping strategies, anxiety, depression, and perceptions of stress. So as we know from the previous literature that we discussed, all of these have a really positive outcome on actual inflammatory bowel disease symptoms, healthcare quality of life, and patient self-image. This also was really interesting that I wanted to highlight that one study, so it's limited because of its sample size, found that the use of ADs or antidepressants was associated with a lower consumption of other drugs prescribed to IBD patients. So this is not that the patients were non-adherent to their medications. This just means that patients had to use lower amounts of things like corticosteroids, which sort of, again, act as the Band-Aid for the exacerbations of flare symptoms in inflammatory bowel disease. And it also found that antidepressant use was correlated to an improvement of the quality of life and also a reduction of the healthcare cost in these patients, which, as we talked about in the beginning of the presentation, can be pretty significant. So the last part is I wanted to highlight a few research-backed ways that we can help these patients, sort of some actionable things moving forward as providers that have been proven to sort of help. So as I had mentioned, my clinic back at Northwestern had those mental health providers directly there by both proximity and accessibility, but that's not going to be the case in a lot of clinics and hospital systems that treat inflammatory bowel disease patients. And so there was actually an analysis I found of 8 randomized and controlled trials, and this was overall done by the Canadian Digestive Health Foundation, and showed that mindfulness and meditation used by apps or other different services outside of mental health providers alleviated chronic pain and greatly improved psychological comorbidity of chronic pain and inflammatory bowel disease. So the reason why I wanted to highlight this is especially when we're diagnosing and managing our young adult patients, patients might not have access, either time, money, or distance to a mental health care provider. But we know that certain programs like apps, other web series programs, or other mental health curriculums has a demonstrable effect on helping these patients' quality of life. The next thing I want to talk about here that IBD providers can do is addressing sexuality in inflammatory bowel disease patients. Again, this is something that can be a little bit of an awkward conversation with and as a provider, but it's really important to arm the patients with the knowledge of what can happen in order to have them sort of stray away from having those negative self-perceptions. So again, the Canadian healthcare system did a research study and showed that these 3 things were very important in terms of educating patients that decreased their anxiety and depression, specifically when it came to sexual dysfunction and inflammatory bowel disease. So as providers, it's really important, as demonstrated by the research, that we really tell patients what the side effects of certain medications are and how it can affect their self-perception. Similarly, it's important to tell patients, especially on certain medications that can, lower their immune response, that STIs can exacerbate a little bit worse in patients with attenuated immune systems. And finally, really arming these patients with the knowledge of being perceptive if they're having any pain during any sexual activity, to really report that, because that can sort of act as a predictor for disease exacerbations regarding their inflammatory bowel disease. And lastly, a huge component that the Canadian Health Department did as well was really figuring out how to make the smooth transition between pediatric to adult cases of inflammatory bowel disease, especially because a large proportion of people being diagnosed with IBD are a lot younger now than in years past. So they found that children were more likely to have extensive and aggressive disease with greater involvement of their intestines, and they're also at risk for a lot of other poor healthcare outcomes like growth, delayed puberty, psychosocial burdens, and weak bones. So a few ways to do this is to talk with the patients and their parents in terms of encouraging them to be more involved in their healthcare visits, especially as they age out of that pediatric population. So a few things that the research study found that was actionable in this is to having the patients track their own appointments, asking questions, and voicing their concerns instead of their parents, and to also utilize services such as transition readiness questionnaires, symptoms tracking apps, and transition navigating services if available. So what these services are there other healthcare workers that can really address children's concerns and sort of usher them into that phase of dealing with inflammatory bowel disease as an adult. And those are my references there, and that's all I have for you guys.
Awesome. Thank you so much, student Dr. Loizzo. Great presentation. And if anyone has any questions, feel free to either raise your hand in Zoom, or if you can't talk right now, feel free to type them in the chat and I'll read them out loud. Dr. Johnson, I think I saw your hand go up.
Yes, you sure did. First and foremost, Doctor, that was an outstanding presentation. The speed at which you went through this was not too fast. It was a good tempo. The quality of your slides was simplistic and easily explained. I thought you had good command of that. So I echo exactly what Anne-Marie just stated. It was an excellent presentation. My question to you is, I have 3 or 4 questions, and I just kind of want to ask you your thoughts. You really got a good background on this topic. From this presentation, was there anything that surprised you? And I say that based upon some common sense corollaries with the chronicity of these recurrent diseases and the effect that it has on a person's psyche. So was there anything that jumped out that would say, whoa, I did not think about that or see that coming? That's number one.
Yeah. What I found, this necessarily isn't super surprising, but what I found was very important was this wasn't a research study or anything, but there was an article that I found when doing the background information for this project that interviewed a lot of gastroenterologists that treated patients with inflammatory bowel disease. And they asked the doctors, what are the percentage of patients, or how many of your patients are relaying to you that they're struggling with their mental health? And how many of those patients are telling you if there's any sort of correlation? And the percentage of that was so low that it really shocked me to see the numbers in terms of a lot of these systematic reviews and these meta-analyses of when patients are asked about it specifically, they're more likely to open up. And I really saw that was really reflected in my own anecdotal experience back as a clinical research manager. So I just think that the sort of discrepancy between patients who are silently struggling with this and having really, really poor disease outcomes, because let me tell you, a lot of people think that inflammatory bowel disease is like IBS, and IBS definitely can exacerbate as well, where a lot of people who don't really know about IBD might think it's just, going to the bathroom a few more times a day. But I've personally seen that Crohn's disease and ulcerative colitis can be really debilitating and life-threatening if it's not taken and handled seriously. So the discrepancy between patients who were really struggling with these things and the providers that knew about it was really shocking to me. And it just showed to me that as providers, we need to be really in tune with our patients managing their chronic diseases, because you can sort of fall into a pit of just managing the symptoms. But I think really understanding and having a grasp of how these symptoms are correlated with patients' mental health can allow you to better serve that patient holistically and comprehensively to manage their disease exacerbations.
Okay, I'll buy that. I think the burden of proof still is in the clinician's wheelhouse, that in that encounter face-to-face, you've got to be thinking about, the doc needs to be thinking about it and inquire. And I think that adds to the quality of the visit, that you are thinking about the totality of the patient. The other, a couple other things. One of them was one slide showed two arrows coming together with an intervention implying that something's got to be done to nip this in the bud right now. What was the most common recommendation for an intervention? Was it starting a mood elevating drug? Was it starting an antidepressant? Was it adjusting some of the the DMARDs or the biologics? What was intervened other than counseling and calling in some troops to help us through some of this? What was intervened? What was done?
So something I found very interesting was, and also sort of tying into your first question about what was surprising, is that a lot of these negative mental health and self-image issues really came actually from medication, medication-induced side effects, as opposed to exacerbation of IBD symptoms. And not to diminish the exacerbation of IBD symptoms, but what a few studies did in terms of intervention, which I thought was very important, was it was sort of a two-pronged approach. A lot of it was implementing mental health upkeep into the patient's visits. And so what that is typically done by is there's a questionnaire, it's called the IBDQR. I believe we use that all the time. And what it really is about a 9-question survey that is just sort of used as an intake form, along with, signing if you've changed your medications or things like that. And this shows the provider automatically before getting into the room if the patient is struggling with their mental health. That was one intervention that one study highlighted, showed that the patient was more engaged with the provider in terms of their comprehensive care plan. And another thing too is that some studies showed that reevaluating the patient's medication and medication course correlated with better results in terms of that direct intervention. And the reason for this is a lot of patients, especially because of the nature of these medications, especially the biologics, don't really know much about what their medication course is. And a lot of patients are surprised to know that you're going to be on these medications for the rest of your life or until they fail. So by increasing that education component in terms of the patient care, at least a few resources that I found positive correlations. And that's a really easy intervention that you can do as a provider, spending 5 extra minutes reevaluating those therapies with your patients. Okay,
well said. My other question is, you had mentioned some of the, let's say the environmental components in the management of your patient, like music and light. Did you see anything else like colors or plants or anything else or scenes that are kind of peaceful and tranquil that would help?
That is a great question. From my search, a lot of the literature right now is more focused on establishing the connection between the two. And there's not a lot done to sort of see what interventions correlate to the best outcomes of these patients. So something I sort of realized while doing this was I was sort of shocked at how little research was done on that. And, that can be from a few things. I think the field of, mental health in terms of managing inflammatory bowel disease and other chronic disease states is sort of new. So there's a lot of new research being developed right now, but I didn't notice anything super specific outside of the ones I mentioned being talked about.
I know Dr. Creamer is going to ask you a question here, and my closing question to you, and you probably already know this, but in case you don't, I just want to share this with you relevant to inflammatory bowel disease. I had a patient at one time had inflammatory bowel disease, didn't know it at the time, and kept coming in with suspected urinary tract infections. And he said, Doc, when I void, I got bubbles in the stool of the commode. look down in the water, there's a whole bunch of bubbles. Do you have any idea what that is? And if not, I'll be glad to explain it.
Well, I know that in some cases, especially Crohn's disease, because it can affect a wide portion of the GI tract, it can lead to vitamin deficiencies and really bad digestive problems for our patients. And we actually had a good percentage of our patients being like, oh, I'm allergic to gluten. And they thought a gluten insensitivity was causing their digestive problems and the inconsistency of their stools. So that might be it. I'm not 100% sure.
Okay, I'm going to help you out there. That's a little pearl that you're going to encounter. That is called pneumatiuria, and it's from fistulization, from the Crohn's disease that fistulized into the bladder. So I missed it, and that's what it was, that's where the air was coming from, hence the bubbles in the stool, the commode water, I should say. And it is called pneumatiuria. Your presentation was outstanding. Thank you.
Appreciate it. Thanks.
Yeah, this is Dr. Kramer. Can you hear me?
Yeah.
Great, thanks. Hey, so a couple of things. First of all, I agree with Dr. Johnson. It was a great presentation. Unfortunately, I had a little bit of audio issue kind of early on, so I had to disconnect and reconnect. So if my question is something you talked about, I apologize. But when we, and this is due to my lack of knowledge, specifically in IBD, but when we see patients coming in with IBD, and you mentioned these flare-ups, is there an increase in say circulating systemic inflammatory cytokines? And if so, which of those are we seeing, or are you aware?
That is a great question. So one project that I actually was involved with, which directly addresses this back when I was at Northwestern, was something as part of the standard of care that a lot of IBD doctors are frustrated about, because in terms of having those levels that we can sort of measure and tell us about the current disease state, as of right now, the standard of care is really only CRP and a fecal cal. And that really, as you know, is not really specific. So there's a huge push in the IBD community as of a few years ago, especially when I was working on this project, to identify different markers that show direct colonic involvement from inflammatory bowel disease. So one thing that we were looking at specifically was CD64, and the project's still going on just because we want a huge sample size. So it started back in 2017, and I think we're still recruiting for it, or Northwestern is still recruiting for it. And so they predict that CD64 might be a better sort of marker for IBD specific inflammation in terms of having a marker that tells us about IBD. Because honestly, if a patient tells us that they're in a flare, standard of care now is to schedule them for a colonoscopy, which a lot of people don't want to do if you're experiencing a really bad IBD flare. It's just, you have to fast for it. You're in a lot of pain. You're uncomfortable. So that is one thing that I personally feel from my experience, the IBD community is really shifting towards in terms of future areas for targeted research, is identifying those markers that might be more indicative of IBD-induced inflammation.
So you did mention CRP. The reason I ask is in some of my own research in working on stress, anxiety, depression reduction, is looking at circulating levels of inflammatory cytokines. CRP is included in that, as well as things like interleukin-6, TNF-alpha, etc. And some interesting research. So you mentioned that there's not a lot of research in this area connecting IBD and mental health. What I would suggest, or at least maybe look into a little more, is don't limit yourself to just IBD. Circulating levels of inflammatory cytokines are now being correlated, and with pretty strong correlation, in patients with different levels of stress, anxiety, and depression. There's actually some indications that there may be some inflammation in different regions of the brain associated with that. So, if there are, flare-ups, if you will, in terms of inflammatory markers, that may be also correlated with some of the mental health symptoms that are going on in these patients as well.
Yeah, that's super interesting. I'd actually love to read more about that. So thank you for bringing that up.
Yeah.
Any other questions, comments? If not, I just want to reiterate again, great presentation. And thank you so much for presenting in our series, student Dr. Loizzo.
Yep. Thank you so much.
Yeah. Hey, if you remind me, just shoot me an email. I'll send you. I've got a kind of review article on some of that.
Yeah, perfect.
Cytokine info. I'll share that with you.
Yeah, like I said, I'd love to read it just because I feel like cytokines is like sort of a hot topic right now in IBD. So I'd love to read that.
Thank you so much again, student Dr. Loizzo, and thank you for everyone who showed up today.
Great job.
Thank you. Take care, guys.